Good morning, good afternoon, good evening. How are you? I hope all are well. Welcome back to the channel. I'm Lindo Sunga, an orthopedic trauma technologist. In the previous video, we discussed more about management of polytrauma in adults. Today, let us discuss about management in polytrauma in pediatrics. There is slight difference between the management of this category of patients in that with the slight difference in management. Polytrauma in pediatrics have undeveloped musculoskeletal structure. Thus, this exposes them to injuries. Sometimes this protects them from some injuries that are meant to occur to them. In management of polytrauma, we will have to calculate the weight using the APLS. That is, weight equals to age of the patient plus 4 times 2, so that we get to know how much fluid, how much medication we are giving these patients. For the treatment of polytrauma, generally it employs primary survey, secondary survey, and tertiary survey. In primary survey, we have ABCDE with the airway. Airway, as we had mentioned before in the previous video, that in trauma cases, we always suspect injury of the cervical spine, thus immobilization of the cervical spine. And then we can always intubate using oropharynx when the patient is unconscious, if the child is unconscious. And then if at all we have to use tracheal intubation, then a cuffed tube is to be used to protect the airway that is very fragile in a child. And doing this, we need to be keen so that we don't do flexion such that we press on the pharyngeal. Thus, we need to immobilize the head, the mid face, parallel to the spine, to enable stabilization of the airway of the child. Breathing. Chest injuries. Children tolerate chest injury poorly because of the undeveloped chest cavity. Thus, you can find that the chest cavity is not able to protect the viscera. Thus, there can be injury to the viscera without really injury to the ribs or fractures. We have circulation. Children. Vital signs of children remains normal until substantial amount of blood loss occurs, and most of the times this can be noted by is usually tachycardia, there is hypotension, there is reduced peripheral perfusion. Vascular access can be done through interosseous cannulation, but this should not be done below a fracture site. Also, we can do administration of fluid by administering 20 milligrams per kilograms of warm crystalloid fluids. And if the patient is not responding, we can also add them a 10 milligram per kg red blood cells. Mostly, this should be done this should be administered using warmers, so that we avoid hypothermia in children. And we go to disability. Disability in children, we use AVPA. We can monitor the alertness of the patient. We can monitor if the patient is responding to verbal command, if the patient is responding to pain, if the patient is not responding at all. And also, we can also help in preventing secondary injury by ensuring adequate cerebral perfusion to avoid or to decrease intracranial pressure. But remember, some of these patients, they have open skull, that is the sutures. Children have open sutures, so most of the time they don't get intracranial pressure, thus they cannot suffer from hypovolemic shock. For exposure, there is already hypothermia, so the children needs to be kept under warm blankets. Room warmers should be used. If fluid is being administered, warmers to the fluid can be used. They can be warmed, those fluids. And then, of course, we have to expose the patient to access injuries that require immediate treatment. On the scoring of patients, on the scoring of pediatric patients, we can still use the previous scores that we discussed in the previous video, but most of the time they use the revised GCS, meaning most of the time their ranges is from 0 to 8, meaning when a patient has with the 0 being severe and 8 being normal. So if a patient have a GCS that is more than 8, the mortality is no mortality. But when the patient has a GCS that is 0, the mortality is 100%. So after both in adult and children, after classifying these patients into giving them the classification, the AIS, the TRIS, the acupuncture, the patients need to, both adults and children, the scores brings us down to 4 categories of classification. We have stable, we have borderline, we have unstable, and we have intremis kind of patients. For the stable patients, we realize that these are patients with no life-threatening injuries, thus they can be treated just normally and be monitored after some time and get discharged. Borderline is what we called in the previous one to be golden hour. These are injuries that if treated at an opportune time, there is great improvement. If not, there is rapid deterioration and mortality, death can occur. And then we have unstable. Unstable, these are patients with life-threatening injuries, and they are mostly under ICU, and they employ DCOA. DCOA is damage control approach in their treatment. That is, if they have other injuries that require surgical treatment until their physiological stability is maintained, they are prolonged. And then we have in extremis. These are life-threatening, completely life-threatening, and they employ DCO. DCO is damage control orthopedics. Damage control orthopedics employs the use of FAST. FAST is focused assessment with sonography of trauma. So this is where the focused assessment with the sonography for trauma. This helps in identification of thoracoabdominal pathologies, like if there is fluid in the abdomen, if there is pneumothorax, and if there is pericardial collections. Also, though FAST is good, it cannot determine single organ injury. Thus, we use CT scan to identify this kind of vascular injuries. And there are some indications where surgical can be done for this kind of patients with life-threatening trauma. Remember, they are in the ICU equally. Their physiological stitches are being monitored on and off. Administration of fluid is being given. The classification has already been done. So some of the indications that these patients would be liable for surgery are if there is an open fracture that is contaminated, if there is head injury, if there is impending compartment syndrome, if there is a vascular necrosis, if there is fractures that are at risk of a vascular necrosis, if there is cardiac tamponade, and if there is also, sometimes we realize these patients cannot really withstand this kind of treatment, so they are managed in the ICU until they are stable enough, and then we can do definitive management of these patients. Thank you for your time. In case you have a question, in case you have a comment, in case you want a topic you want us to discuss, kindly feel free to write in the comment in box. And thank you. See you in the next one.